Hello, I'm Janice Karen, Director of Integration Technologies at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. And let's go ahead and move to the first update. So the official name, the Advancing Interoperability and Improving Prior Authorization Processes proposed rule, was officially published in the Federal Register yesterday. CMS did a presentation last week with an overview session, and they highlighted a few things that were not, some of which were obvious in the reading, but they also pointed out a few things that may not have come through at first glance, and talked about a couple of other pieces that may be in the offing. So the first thing that they highlighted, which is something that we did talk about last week, is that the rule has the same basic structure and features as the frozen rule that was put out 2 years ago, but some of the details have changed. So what that means is that it includes some changes and additions to the patient access API. It includes a new provider access API, which is exchanged from payers to providers. It includes a requirement for FHIR for the payer-to-payer access and support for bulk, and a process by which people can do the opting in during the enrollment process, as well as some RFI. And of course, on the prior authorization side, it includes a process which is very similar to the Da Vinci process, and but does not actually require the use of the Da Vinci implementation guides. So any questions about the really overall overarching view of the rule before we go into some more of the details? All right. So the implementation, we had mentioned that we saw the implementation date for at least most things was January 1st, 2026. CMS confirmed that that is the implementation date for everything that's included in the rule. So it's basically do everything at once, the whole shebang, 3 years from now. One thing they pointed out specifically is that the prior authorization components do not cover medication or drugs. It is only for other medical services. So I don't know how obvious that is for reading. I had not picked up on that, but I had not fully looked at the prior authorization sections in excruciating detail yet. Another thing that they pointed out is the time frame that you have for adding prior authorization information into your patient access API flow. So you have 1 day from the point that any prior authorization related information comes into your system or is adjudicated, or whether it's something that comes into your system or something that's processed by your system. You have 1 day from the point that that information is available to push it into your patient access APIs and have it go out to patients via that process. They also pointed out that the provider access APIs, and again, this is the API that is going from the payers to the providers. It includes everything that's in the patient access API with the one exception, and that is the specific cost sharing information. But it includes everything else. The one thing which is slightly different from what was in the frozen rule is that payers must support an opt-in process for the payer-to-payer exchange during enrollment. So they must have a mechanism during the enrollment process which allows a patient to indicate whether or not they want their records from their previous payer to be moved over to their new payer. And then so that is slightly different from what was there before. That was something that they talked about having an optional process for that. in the frozen rule, at least that's the way that I remember it. But it was not, so that's something to look at. If I remember correctly from the frozen rule, that entire process of the enrollment and opt-in and doing the bulk was one of the more, one of the changes that looked like it was going to be the hardest to implement from the frozen rule. So we will definitely be taking a longer look at that and looking at that in a lot more detail as we move forward with our explorations of the rule. Another thing that's a little bit different is that there was a reporting requirement for data in the frozen rule, but they changed it a little bit, and the reporting requirement now is not a reporting requirement to the government, but actually a reporting requirement that each payer must put on their own must publicly post on their official website. So there's a specific list of aggregated prior authorization data that they have to post publicly and have to make available on their own website. Another thing that they talked about without much detail is that they're proposing a new quality measure that reports on the use of prior authorization and all of the other APIs. And then the last thing that they talked about, which was a surprise, and they did not supply a lot of details, and is a bit concerning, to be honest with you, from my perspective, is that they want to adopt a process similar to the ONC's SFAT process for advancing the standards that are in a rule. Now, to refresh your memory, the SFAT process is allows for optional use of more advanced standards that are specifically listed in a certification or a rule. And that means that if folks may need to support multiple versions of the same thing at the same time in order to function with all of their different exchange partners. So, and that is, so for instance, right now, US CDI is officially still version 1, but optionally you can certify against version 2 if you wish. And there was no detail about exactly how CMS would implement such a process. It is more concerning, I would say, when you're talking about an actual API doing having the support, because remember, a lot of these things are not backwards compatible, not required to be backwards compatible. So it is very unclear exactly how this will roll out. I did ask a question about that, and they did not get a very robust answer. So we will continue to try to sort out what's happening on that front. So does anyone have any questions, any thoughts, any comments about any of this?
Hi, Janice. This is Vijay Bhatt.
Hi, Vijay.
Hi. I have a question about the payer have 1 day to add new prior authorization info to patient access APIs.
Yep.
Now, are these approved prior auths, or because
there's a bunch of
Nope.
different information. I'm
Yeah.
sorry, I didn't mean to interrupt you. Go ahead, Dave, if
No,
you want to answer, go ahead.
I can clarify. Yeah, it's all historical, current, or pending. So it's all prior auths that are
Okay.
outstanding. Yeah.
Because we get a ton of them via fax. And would those also be included as part of this need, or only the ones that come via the FHIR protocol?
No, it's supposed to be all prior auths that the payer has a record of, no matter which mechanism they were received by the payer.
Okay.
Yeah, that's the plan, Vijay.
All right.
Now remember, the expectation is that at the point that this goes into effect, the electronic prior authorization stuff will also go into effect. So presumably there will be at least less, if I don't think anyone expects it to, no one is naive enough to think that there will be 100% compliance on the exact date it goes into effect, but presumably that will help. And at that point, more and more of the prior authorization stuff should be done electronically.
Thank you, Dennis.
And then that what ties it back, VJ, to your side is the MIPS reporting, quality measure reporting measure, which will be a numerator denominator calculation based on the total number of prior auths and then the percentage of them submitted electronically.
Okay.
So it'll be numerator will be number electronically, the bottom, the denominator will be the total prior auths that you're submitting.
Okay, got it.
Yeah.
Thanks.
Yep. And the one piece, I don't know, Dave, if you know this, but it's not clear to me from the amount that, and I as you can tell, I am still plowing through this. But it's not clear to me whether the medication and drug piece is actually part of, even though it's not part of the prior authorization requirements for the prior authorization exchange, it's not clear to me whether it's still supposed to be part of the information that goes into the patient access APIs and the provide, all of the other APIs that are getting fed information. Dave, do you know that?
My gut tells me no. And the reason it does that is because most of those medication prior authorizations go through a separate intermediary. So they'll go through a PBM process for authorization. So the payers very likely won't even have access to those drug PA requests within their systems, within their medical management system.
But they require other information that's from the PBM to go in the patient access API already, because other medication information that may not be processed or held by the payer directly is already required in that API. So that's why I'm not sure.
Yeah, I'd leave that as a good question for a future date, Janice. I'm not sure. My gut tells me no, but basically because it more or less just said none of this applies to drugs at this point. But you're right, it didn't go into specifics about that regarding measures or even additional data through the patient access APIs or any of the prior auth details there. So
it wasn't clear to me if the comment was specific, like it was in the context of talking about prior authorization, but it wasn't clear to me if the comment that was made about the medications and drugs not being covered was more expansive than that or not. So that definitely is an open question to be determined.
Yep.
But
for sure. The only thing I'll add, Janice, that wasn't listed here on your list is that the reporting, the response requirement timeframes have changed also. I don't know if that's important to talk about here, but it's now 72 hours in the proposed rule for an urgent PA request that the payer has to respond. And then it's 7 calendar days for standard non-urgent requests. And that's
actually the same as the frozen rule.
Yeah, okay, so, there you go.
Yeah. So that's that was not highlighted in the presentation. So I absolutely there's a ton of other stuff that we're going to need to point out that's in the rule itself that people are going to need to know, and we definitely will next year. We will be looking at this section by section in a lot of detail as part of the main thrust of the DGC meetings. But so these were but I also thought it was interesting to note. So these were also part of what's interesting about this is not just the information, but these were the things that CMS chose to highlight during their short presentations.
Yeah, and honestly, Janice, there's other things like gold carding is allowed in the new rule. That they didn't talk about that at all. I mean, the things that they talked about, I was on that meeting. Were kind of the highlights that they chose to talk about, and so the rule itself has other details, to your point, that we really need to go through and tease those out at some point.
Yeah, but sometimes you can learn a lot by what they choose to talk about versus not talk about in terms of
absolutely
in terms of enforcement, in terms of additional things they're thinking about doing in the future, etc.
Yep,
so
absolutely. Yeah.
Anyone else want to comment? Have any questions?
Well, it's interesting that they are explicit about payer-to-payer exchanges, because it was certainly my experience, at least in the Massachusetts group commercial insurance market, that the transfer of open auths from payer to payer when a group moves to their insurers happens as a matter of course. In
Oh,
fact,
really?
brokers kind of insist on it.
Interesting.
So are you just, so what information is happening with that exchange? Because remember, this is all of the clinical data, encounter data, claims data. There's like, it's like basically.
I thought it was just about open auths.
Well, I think what we're talking about two different things here. So we're talking about what authorization information gets traded between the payers with a payer data exchange versus also what goes in the payer to member or payer to patient data exchange. So there's both of those, but at the same time, they're essentially the same. It's the same data set. There are actually, by the way, no real clear specifications on how that data is to be sent yet. So that's a kind of an open question. But to your point, John, I think that as that information was shared previously in those exchanges when a group would move or whatever, that's an area where maybe Massachusetts is ahead of the regulations to some degree in that requirement. And I don't know if that was a requirement or just a nice thing to do or where that came from. But
I think the latter.
yeah, it could be, and that's great. So that'll really be a leg up as these APIs come into play, because
because right now, of course, it's all proprietary formats and that kind of thing.
Exactly. So the specifications, as I said, aren't really clear yet. And also there is this notion of a bulk data transport payer to payer. I don't know if you saw that in there as well. But
that's related to the enrollment portions. The way that it was set up, I have not gone in detail in that part in the new version of the rule. The way that was set up in the frozen rule was that for 30 days after the enrollment period ended, you would send anyone who opted in during enrollment in bulk. And there was a lot of, that was one of the areas where there was some of the inconsistencies that had cropped in with the speed. So that process was not 100% clear in the frozen rule, and there were some questions around the consents in particular, around consent in particular. But if I remember correctly, but the bulk piece would be used at that element. So if there wasn't a standard enrollment period, then I believe that you had to do it once a year at the end of Q1 of the year. But then for each plan, if there was a set enrollment, you did it. It was 30 days after the enrollment period ended, and then so it was a once a year thing, and then the rest of the year, it was the individual patient request. So the individual patient request, which is what was in the original interoperability rule, still has to be supported. Still has to be supported the same way. I, as a patient, can request that at any time within the allowed time frame. I believe it's 5 years. I believe it's 5 years. But it's been a while since I've looked at that, so I could be misremembering. So I, as an individual, can still request the individual transfer at any point within the window in which I'm allowed to do that. But the bulk comes in for the people who do it at enrollment times, and that's something that's supposed to happen once a year per plan. Does that make sense?
Mm-hmm. Yeah. And the question that I was raising, though, on the point of question I was raising on that, Janice, is that does the exchange of prior auth information include as a part of a transition to what John was describing, when like a group moves from one health plan to another? Let's say all of a sudden everybody goes from, Blue Cross Blue Shield of Mass over to Tufts Health Plan for their benefits, and there's 500 people in that group. Does every prior auth transaction move as a part of that process of moving those members over, including the history going back and any current open status?
No, historically it's been approved open authorizations. In other words,
Okay.
ones the patient might need to exercise after they've been
Gotcha.
moved to a different carrier.
Yeah, because
Gotcha.
you definitely have to, the key thing that I highlighted in all of the previous discussions was the importance of moving the pending ones in particular.
Yeah.
Because what they wanted to avoid, and I mean, this is true for open as well, but what they wanted to avoid basically was having to reinitiate things that were already in process.
Oh, totally. Yeah, absolutely. Delay of service, all sorts of things could occur as a
Yeah.
result of that. Yeah. Okay, that's
And I'm sorry if I misunderstood what you were saying with the John with my question. It sounds like I might have based on how you answered Dave's follow-up.
Yeah, I think we
So,
covered it. I think we covered it, John.
yeah, I
John,
think we're good now. So,
okay. Yeah.
anything else that people want to talk about here? Like I said, we'll be going into all of this in a lot more detail, and I certainly have a lot more reading to do, and I'm sure that there'll be other events and industry things that I go to get other people's thoughts and opinions on things as well. And we'll bring all of that back to future meetings next year.
Okay.
All right, hearing nothing else, let's move on. So this is interesting because it came via email from CMS. As far as I can tell, this is nowhere on the CMS website. But there are some changes to the IDR process where they're basically requiring additional documentation of cases where where someone is arguing that the dispute process does not actually apply to an initiated dispute. Now, what's interesting is that in the email, which is rather lengthy, CMS indicated that these attestations and additional information should come from the IDR entity, not the non-initiating party. And in most of the cases, to me, it seems more logically that it needs to come from the non-initiating party. Although I guess the answer could be that the non-initiating party is supposed to supply it to the entity who then attests that they've received it. But so I have actually sent email to CMS to confirm that process. I have not heard back yet. I mean, it's only been like a day and a half, so it's not, not unexpected. But so basically, for most of the situations where someone might initiate a dispute under no surprises, and it doesn't fit the rules of the dispute, basically you have to include a lot more documentation starting on December 19th to show that that's actually the case. So one of the reasons why something might not be eligible for a dispute is that it falls under the state rules for how things get priced. It might be an all payer model. There are a couple of other reasons. And so if that actually is the case, then you have to cite the relevant state law with documentation confirming that it actually applies to this situation. You have to complete the open negotiation process before you initiate a dispute. So if that wasn't completed, then the date that it will be complete needs to be provided along with documentation of the start date. If you only have a limited window, I believe it's 4 days to initiate a dispute after the open negotiation period ends. So if you try to dispute after that, then you have to supply the date when the window closed and proof of when the window opened. There are also some items and services that are not eligible for no surprises disputes. And so if it's not eligible, then you have to include a list of the items and services that aren't eligible and the specific reason why each one isn't eligible. Let's go ahead and go on to the next slide because we'll just talk about all of them. So again, there's certain coverage types that are not eligible. And so if there are services or items that are in that coverage type, then you have to, excuse me, you have to list them and supply the applicable coverage type for each of them. For this initial period right now, we're also just getting to the point where every plan is covered by no surprises, because remember the rule was plan years starting after January 1st. So basically December 1st was the last, or even I guess it's possible someone starts off month, later in the month. So basically when we hit January 1st, 2023, this reason will no longer be viable. But if your plan year started before January 1st, 2022, then those services are not eligible to be disputed, and or they basically don't fall under no surprises yet. And so you have to document the plan year start date in that case. And again, there might be some items that are not covered by the policy that someone tries to dispute. Then you have to provide documentation of the policy showing that it doesn't cover those items or services. The last two are again back to sort of no surprises the way it's administered, which is that there are rules about how you can batch items together. And if there are items or services that don't meet those rules, then you have to list each item that doesn't fit and indicate which requirement is not met for that item. And then finally, there's a 90-day cooling off period where you can't redispute the same items again for 90 days. So you have to basically abide by the previous rule and apply it to any new items or services that fall within that 90-day cooling off period. So if you try to initiate early, then you have to provide both the dispute number and the copy of the determination of the previous dispute to show that the service actually was covered by that dispute and that you're still in the cooling off period. So those last two, there are a couple of these that I think definitely could come from the entity, but most of these are things that would be known by the disputing parties. So that's why I asked for clarification. Anyone have any comments or thoughts or questions here? All right. All right. So I think that they just I think they just wanted to have some documentation to back up decisions that were made. Although some of this seems a little bit overkill to me personally. All right. Thanks, Dave.
Yep.
All right. Oh, I'm sorry.
Next one. Oh, I thought you might go to the next one.
Go ahead back.
So this is the IDR. And then
no,
we'll
yeah,
to,
I'm sorry.
Yeah,
go to the next slide.
Gotcha.
My apologies. I was responding to something I didn't realize was sent directly to me. So the last thing that we're going to cover today is that the FDA has posted some information on augmented reality and virtual reality in medical devices. And it's an interesting page. It talks a little bit about what AR and VR are. And just as a really quick overview, if you're not clear what the distinction between them is, augmented reality is kind of an overlay on top of reality where you see both. And so it's putting some, like for instance, it might be putting, one good example that's currently in use is overlaying the internal features of a patient on top of them to assist with surgical procedures. It can help you be more precise in the way that you make incisions or the way that you go towards something, because you can actually see sort of a view of what you're trying to reach before you cut into someone. That's one example, but there's lots of other things like that. Whereas virtual reality is basically completely replacing reality with a new interactive simulation. So they go into some more detail about about that and some of the medical implications of some of that. They talk, in particular, they talk about how they're used in medical devices. And then they have some discussion of the potential rewards and risks of using both of them. And they talk a little bit about the types of devices and treatment domains, and it's pretty broad, actually. And then they look at a partial list of approved medical devices, which they plan to update. This is an automated list, so they say it's not complete because there may be they base it on descriptive terms in overview descriptions. And so if there may be devices that are approved that use AR or VR that don't highlight it in the little bit of text that they're basically automatically searching through to pull stuff out. So they say it's not a complete list, but it gives you a sense of some of the types of devices that have been approved that use either technology. So I found it to be a really interesting page and a pretty good look at this technology and some of the ways that it's used in healthcare, and some of the things that might be coming that we might need to think about from a data perspective, even though it didn't go into the data specifically. I thought it was pretty interesting and worth a look. So you can find the link there. Any comments or questions there? All right, then let's go on to the next page, please. So I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at the email address on the page. That's dgc@myhealthdata.org. Thank you very much, and we hope to see you soon.